right, thank you for staying with Daybreak. This is a special version of Daybreak. There's an extended interview here with Dr. Grace Vugutsa. She's a medical coordinator support MSF. Daktari, thank you for making time.
Thank you, it's my pleasure.
I took my time not to say the full name because there's always been a debate. So how do you even pronounce it? Is it Médecins Sans Frontières? Is it, what is MSF?
Médecins Sans Frontières. It's a French word.
Brilliant. So what is MSF? Let's start from there.
Well, of course, question of the hour. MSF is an international medical humanitarian organization, and we were founded in 1971 by a group of doctors and journalists. And the main aim is to provide medical assistance to populations in need. And these populations are populations that are affected by epidemics, by natural disasters, by exclusion from healthcare. And really, these are the populations that we seek to serve.
I've seen that you deliver emergency aid to people affected by armed conflict, epidemics. How risky is that job?
Oh, yeah, it's definitely quite risky. And I think that's why our independence is super vital. And the rootedness in our principles is extremely crucial because this is difficult work. By the time you're asking someone to give of themselves and give of their energies, their resources, their skills, really to go into a difficult place and give these services to people who need them, it's quite the commitment. So for sure, in some of these areas, it can be quite challenging.
Yeah. What has your experience been like as a person working for MSF, especially in those challenging situations when there's a disaster in the different places? How has that been?
Well, I would have to say it has been life-changing, first of all, because initially when I entered the practice, it was different working in a more stable context and how the tables turn in a disorganized context where there is no health system, there is nothing to hold on to. And so we're all up in the air, and really you have to come together. The doctors are not higher than anyone else. We all come together, we all pull together to give some of these services. And it's really, it changes your life. It changes how you see it, and it changes how you contribute to society. Okay.
When did MSF start working here in Kenya?
In Kenya?
I estimate,
initially, it was in 1987, where we were just a presence in the country to support our other activities in our neighboring Sudan and Somalia. And then by 1991, now we were moving to supporting the refugees in Kenya from Sudan and Somalia. And then since then, our programs have evolved to different places in Kenya and really moving all over the place and helping these populations in need. Yeah,
and here in Nairobi as well, I see there are different places, or in Kenya in general, there's Eastlands, Mombasa. How has that been?
Well, given the different types, as I said, we're really led by the medical needs. So you might find that our programs are so different in different places because of the medical needs. For example, in Garissa, we are providing primary and secondary health care in one of the refugee camps in Dadaab refugee complex. But that's very different from the project that we have in Mombasa, which is an adolescent and youth population project. In Nairobi, we are really targeting to support survivors of violence, and this is inclusive of sexual and gender-based violence, and that's within Nairobi. And then in Homa Bay County, we have primary and secondary healthcare, but now for people with chronic disease, particularly non-communicable diseases. And this is inclusive of diabetes and advanced HIV. Yeah.
In fact, that's where I was going to, because I saw earlier on when I was reading through what MSF does, that in Homa Bay, you're focusing on non-communicable diseases and advanced HIV. And yet just a few moments ago, there was a report that there seems to be a rise in HIV infections. What do you think is causing that disconnect? In as much as there's a lot of intervention, but there's still new infections. Is it not communicated well enough? What is happening? Are people more nonchalant now? What is it?
Well, we have been the fight against HIV and AIDS has been a long one. And it has been a priority in global health all over the world. And even just as a part of this commitment, MSF was amongst the initial organizations to give free antiretroviral therapy in 2001. So this fight has changed. And also, as you can see, so many things in the landscape, in the health systems are changing. So as we cannot, because we only work in that one place, we cannot state the entire, the implications of, for example, HIV or health programs for the entire country. But we can say it's really somewhere that needs a lot of emphasis. Mm-hmm. Yeah.
The other issue is SGBV. I see in Eastlands there you're responding to urban violence, including sexual and gender-based violence, yeah. Youth-friendly services.
Yeah.
What does that look like? What are youth-friendly services?
The youth-friendly services, this is a demonstration also of our collaboration with our partners, because that, I think, was something that's very, very important. It is already part of the national strategy of making healthcare more accessible to adolescent and youth populations. So this is not a new concept, but this is just something, a framework that we are supporting and building on to ensure that more people can have some of these services. And we have heard from the people who come to seek healthcare from us that, this has been a haven for most of them, a place where they can seek solace and they don't feel they have no reservations with seeking healthcare from this. And I think that's really what we want.
Yeah. In your experience, what is the best way of dealing with this SGBV? Because I divert into that because it's something that is of concern a lot lately. In fact, most of the research shows that it's mostly done by someone close to the person.
Yes.
So when you have these cases, how do you deal with them, and what is the central message to these people? Because it's a very tricky balance. Most of the time it's someone they know.
Oh, yes. Yeah. Oh, yes. And it's something that we've seen reflected in our data as well. Yeah. It's an extremely complex and many times unfortunate situation. But our role really as a medical organization is ensuring that these people are not only given the medical services that they require, but also the psychological support and linkage to the legal services that they need. So I think that framework is extremely important to ensure that there's continuity in the system. Yeah, so just that is really the bedrock. Yeah.
Is there something about the position of the counties that exposes them or makes them vulnerable to certain things? Like in Mombasa, the issues you're dealing with there is very different from Homa Bay.
Yeah.
In your experience, does that play a part, vulnerability or the positioning of the place? Say, for example, Mombasa, now that it's an entry port and an exit port, are they more prone to drug abuse and all that? Or is it just a people and their culture?
It's multiple factors. It's multifactorial. So most times you can't attribute it to just one thing. But as you said, it is an observation that is seen with many countries in the world, that certain things are more likely to occur in certain places. And so before we start a program, we do send out a team, and the team evaluates what are the most pressing needs. And based on these needs, we then channel our resources and we channel our expertise to be able to support that population in that area.
Yeah. Talk to us about Dadaab. What is the focus there?
Yes.
In Dadaab?
It's a project that we've had for quite some time, and this is provision of primary and secondary health care within the Dagahali refugee camp. It's one of the 4 camps in the Dadaab refugee complex. And so this really looks like providing, we have 2 level 2 facilities, and we have 1 level 3, which is the MSF hospital. And so through this, the refugees who are within that camp can come and receive healthcare. And so this is healthcare in all its facets, inclusive of community health, inclusive of vaccination, inclusive of any kind of emergency response also within the camps. That is within our purview as well.
Yeah. We know now that there's a report showing that about 2.1 million Kenyans are facing starvation.
Yeah.
How is the intervention? How does MSF intervene in such circumstances?
Well, we are first and foremost a medical organization. So And in many ways, we have certain limitations. So which means we have to assess medical needs, and then we respond to the medical needs. So you might find that in certain instances, you do have let me say, a disaster, and then we would have to go and assess the medical needs, and then and then respond to those medical needs. So it's a bit, we have to balance our resource as well as our the medical needs.
Yeah. Speaking of resource, where does this resource come from?
Yeah, a really good question in this changing landscape. Yeah, it's a very, let me say, unique model, because MSF relies heavily on private donations. That is individual donations, my donation, your donation, everyone's donation. And I think that's an extra layer why it makes it such an honor that people have given us the privilege, the responsibility to do this work for them. And this is really quite the honor, and we take it very, very seriously. Because then if we get yours and we get yours, and haba na haba, we get a pot that we're able to really conduct our services.
Yeah. So what does this structure look like? Are they doctors who are volunteering and they still have their own practices, or are they now officially with MSF? How does it work?
Since we have different kinds of professionals, and you asked about the doctors, some do come on a voluntary basis, and then there's some also who have to be employed, because we need some of the services, and it's really dependent on the nature of the program. So you can see how a different program, one that is giving primary and secondary healthcare, would need someone more regularly, as opposed to, let's say, an emergency program that only runs for 3 months. So really, these are the kind of the administrative things that we have to consider.
How do you decide what to respond to and where?
It's really guided by the medical needs, of course, as I earlier said, and then second, guided by our limitations. As with everyone else, we have finite resources. And with finite resources, then you have to see, how do I best allocate the resources that I have to be able to get the best impact or the most impact. And of course, our guiding aim is to provide the best quality of care that we can and act in the best interest of the populations that we serve and for our patients. So guided by these principles, then we're able to make a decision.
So as the medical coordinator, how does this information get to you? Do you base it on phone calls? Do people send you messages? How do you get this information so that you decide that this is where we're going and this is what we're going to do there?
Yeah, it's actually quite the balancing act, because we have multiple tiered systems, I would say. We have our teams on the ground, and we also collaborate. We collaborate not just with other partners. We collaborate with the various departments of health. We collaborate with the Ministry of Health. We collaborate with other partners, and we also collaborate with the communities that we serve. And so you see, then we have information layers that come from different parts. And of course, once we receive an alert, then we have to verify it. We send a team, and then we are better able to elucidate what are the needs. Once we know that, then we're able to design the kind of intervention that needs to be done. Yeah.
The year 2025 is coming to an end, but when you look at it, what are some of the emergencies that MSF responded to? Some of the highlights for you, because I know you was in the thick of things. This is what was going on.
For sure. It's been quite a number of emergencies. And off the top of my head, I would say that there's some that really did stand out for me. And the first would be response in Wajir and Marsabit for Kala-Azar, so visceral leishmaniasis. And then the second one would be the ongoing Mpox response in Mombasa. And that has been, again, with very, very deep collaboration with the Mombasa Department of Health. We also responded to cholera outbreaks in different parts of the country. We also have measles in Baringo. And all of these things have really brought us a different facet, and we're continuously learning, continuously evaluating. And it's really, really been an honor
Yeah.
Yeah.
We also saw you when there was protests.
Yes.
And we saw you responding to some of the injuries there, in fact, putting yourselves on the line and at risk, essentially.
Yeah.
What goes through the minds of your people when such a thing happens? Because it's not as simple as just a protest. There's political innuendos to it. How do you then this balance? Or for you, is it just about saving lives and that's it? It doesn't matter what happens?
That's a good question, because this is also one of the biggest things that even our founders had to grapple with. At any time when there's conflict, there's two people who are at odds with each other, and a decision needed to be made that MSF would be neutral, MSF would be impartial, and would prioritize the medical needs. And as you already said, our teams are trained. Once they get in there trained, there are certain things that they have to emphasize when they're working in areas of conflict. So Kenya would not be, or those instances would not be the first time that MSF teams are working in very volatile situations. So also we don't send them out unprotected. We have guidelines, we have protocols, we have rules really that safeguard the people who are working. But also we do not discriminate depending on either side. We're not going to take any side. Anyone who requires medical assistance is going to get it from MSF.
Mm-hmm. I know you also responded to the landslides in Elgeyo Marakwet there, and there's always a lot of concern about the follow-up. So how do you ensure that there's some level of follow-up so that it's conclusively dealt with, rather than just a quick emergency response and you're out?
Yes.
Or is that how it works? What happens? Is there a follow-up to ensure that this is settled, done and dusted?
Yeah.
What happens?
Well, in this let me say, ecosystem, there are different roles, and I think that's why I was saying collaboration is such a big part of what we do. Because as a medical organization, we can go in and assess the needs, but then that is in the acute setting where there is, everything is up in the air and we need to help the system get back on its feet. However, we also need to collaborate with the local governments, with the local departments of health, with the local structures, with the local people, because even after everything is settled, those systems are the ones that we need to help strengthen. So it's really collaborative, that there is some help that comes in the acute phase, but then there really is also a plateau phase where we need to continuously follow up, but also to support and strengthen the systems that hold these areas up. Yeah.
There's been a general complaint from everybody else that donor funding is shrinking.
Yeah.
Has MSF been affected by that? And what is the alternative going forward?
Yeah, for sure the aid space needs a big, we need to, there's lots of conversations that are already taking place about the aid and the organization of aid. MSF, as I said earlier, we receive private donations. So we haven't been directly affected by the funding cuts. However, we do work in collaboration with other partners who have been affected. And so, as I said, this is an ecosystem. We are limited in what we can do as MSF. And so other partners, other collaborators usually take up, and this is what we call, the health system. So in this system, then we need, some restructuring to be able to see how to best navigate these times, Yeah.
Usually when you talk about such organizations, I like to find out from the people who are at the helm what inspires them to join that organization. And for you as Dr. Vugutsa, why MSF? Why not anywhere else?
Well, MSF, I remember first hearing of MSF much younger, and it was on the news, and they were in really some difficult place. And I remember the testimony of one doctor saying that experience changed their life. And for me, that's what I wanted. I wanted to use my skills to cause a bit of that change. And there's a way that once you're a part of that change, it changes you too.
So you're just to be part of the change?
Yes.
Okay. The final parting shots for this conversation. We're running out of time here, but what is the one message that you'd like to send out to the people?
Well,
or anybody who's watching, what is the central message that you want them to hear from you this morning?
Well, MSF is a medical organization, and it requires support from individuals just like us, you from me, and that is key to our mission. That we are able to reach the populations in need is the biggest aim.
Yeah.
Yeah.
Looking into the future, now that we talked about population, and sorry, we as journalists, we always just get these questions coming through as the more you speak about these conversations. We are heading into a time when now there's the use of AI and technology.
Yes.
How are you planning to adopt that to make sure that functions around MSF are more efficient? Yeah.
There's always in an organization people who are also thinking about these thoughts. And as an organization, we have had ways, we've had to sit down and think, how can we adopt these new technologies and leverage them to be able to get better results? We do have some ways of leveraging it into our, let me say, workflows, but really, given our work on the ground, that really does not change. It still needs the dedication of the people who join MSF to be able to go out into those places and do the work. Yeah.
When you talk about contagious diseases like Mpox, you mentioned earlier on that you responded to that in Mombasa.
Yeah.
How does that look like? So before a response to a contagious disease like that,
yeah,
what are some of the back-end procedures that you look through to ensure that your own people are safe?
That is the biggest thing in such instances is infection prevention control, what we call IPC. And this is usually also the height, for example, in other infectious diseases like Ebola or Marburg. And so in diseases where we don't know, the aim is to prevent the transfer of those infectious pathogens from one person to another. And so usually it means our protocols, how people don and doff, what people wear, what they need to do, how the surfaces are kept. So it's really, really a very deep and intricate method before we send people. We need to make sure that they are protected. In instances where there is a vaccination available, we ensure that our people are vaccinated before going to give of their services and of their help. Yeah.
I'd mentioned where you work earlier on and how you prioritize, how you choose what to respond to. Is the magnitude of it all, does that matter? Like if you decide as MSF that you're going to intervene in Mombasa and not Kisumu when they're facing the same issues, how then do you pick? Is it the population that is affected? Is it the distance? Is it the people? How do you decide?
There are multiple
Because there are two
factors.
different things. I mean, there's the location, and then there's the people affected.
Oh, yes.
Yeah. For example, if something is affecting more children, is that something you would respond to faster than if it's a different team?
There's many different factors, and some also that I would add to what you have put is also the presence of other actors. For example, if there's someone else also who is keen to do that, we would not want to duplicate our efforts. Really, the utilization of resources is something that we prize highly, and so we need to see, okay, since we are finite, we have finite resources, we are limited, we then need to see, okay, this is how we distribute, this would have the most impact. And so that impact is, of course, measured by different things, but really that's how we go.
Speak to us about more that collaboration you're talking about with something like the Ministry of Health.
Yeah.
So how does that work? When you get an emergency, do you first call them, or do you just show up and then decide once you're on the roll?
No. It's first and foremost the responsibility of the government to provide health to its people. So the role of MSF is not to replace the government. We are not in any way replacing what the government is supposed to do, but rather supporting its interventions, supporting its mandate. So we are not going and doing our own thing and then expecting them to follow. No, we are in active collaboration, active discussion, so that once they also, because from their end they have information that we don't, and so we're able to get a more balanced picture. And then we're able to better deploy our resources, because then they also have plans to respond to some of these emergencies. So we wouldn't want to do the exact same thing that the government is doing, but rather as an adjunct or as a supplement.
Yeah. Having been in this medical industry for quite some time and as a doctor yourself, what do you think is the best practice for effective universal health coverage. How would that model look like?
That's a difficult question.
I know.
Yeah.
You can pick one line even if it's your line.
It is a difficult question, and difficult in the sense that there are multiple factors, because something can look very clean on paper, and then you take it to the field and then it doesn't work. And that's a really it's a common problem. And so the way of primary health care and preventive care, where the world is going, that is really something that needs to be, enriched, and a model that is very good, because instead of curative services that tend to be more expensive, most of the studies have found that preventive services are better and they are more cost effective in the end.
Okay. I want to bring you back to the HIV and AIDS, because it's World HIV and World AIDS Day was just on the 1st of December, just within this month. And in Homa Bay specifically, there's been a lot of conversation in terms of, are we warning people enough, or are we creating stigma in the process? Because depending on which time you grew up, there was a time when there was actual figures of people who were suffering from HIV and AIDS, and it somehow deterred people from engaging in irresponsible sexual activities. And at this particular point, now that conversation has shifted into stigma. So where do you draw the line in between actual warning and stigma as well? But for the people, what do they tell you when you interact with them?
I think in many of those times that you were referring to, education is really important. Health promotion, when a person knows exactly what they need to do, they're more likely to follow it. So and when they have the less knowledge they have, the more likely it is that they're going to be myths, and the more likely the stigma is going to be there. So really, health promotion, health education is really very at the core of some of these programs. And that's why you'll find that you'll find even at those earlier days, you'd find messages in the media, you'd find them on TV, and they would tell you exactly what you should do. And that's really the kind of education that people need. They need the direction, and they need the power to make their own choices.
All right. Thank you so much for speaking to us this morning. Unless you want to send a shout out, it's Christmas. If you do, it's fine. You can go ahead or not, whichever one works for you. All right. Thank you for making time, Dr. Grace.
Thank you so much. Thank you. It was a pleasure.
Medical Coordinator Support, MSF. You said the pronunciation is?
Médecins Sans Frontières.
I will let you handle that.
Thank
Coming
you
up
very
next
much.
is Level Up. Bye for now.